Bladder cancer, clinical presentation, diagnosis, and management strategies. Bladder cancer represents a significant urological malignancy characterized by abnormal cellular growth within the bladder epithelium. Early detection through recognizing warning signs and appropriate diagnostic procedures can substantially improve treatment outcomes and prognosis. Understanding bladder cancer, an overview. Bladder cancer develops when malignant cells arise within the tissue lining the bladder, a muscular organ responsible for storing urine. The disease occurs when genetic mutations cause cells to divide uncontrollably, eventually forming tumors that can invade deeper layers of the bladder wall and potentially spread to distant organs. This malignancy ranks among the most common cancers affecting the urinary system, with incidence varying significantly based on geographic location, age, and exposure to risk factors. The disease's impact extends beyond the bladder itself, as advancing tumors can compromise bladder function and affect surrounding anatomical structures including the prostate, rectum, and adjacent lymph nodes. Clinical presentation and early warning signs. The most characteristic symptom prompting medical evaluation in bladder cancer patients involves the presence of blood in the urine, a condition medically termed hematuria. This manifestation can appear either macroscopically, where visible discoloration occurs in the urine stream, or microscopically, detected only through laboratory analysis. Patients frequently report additional symptoms that develop over weeks to months, including persistent urinary frequency, urgency with voiding, and dysuria or discomfort during urination. Pain in the lower abdominal region, pelvis, or lower back may also develop, particularly in cases where the malignancy has progressed beyond the initial site of origin. Constitutional symptoms such as fatigue and unexplained weight loss can appear in advanced disease stages when significant tumor burden is present. Key points: visible or microscopic blood in urine, hematuria. Increased frequency of urination and nocturia. Painful urination and bladder discomfort. Pelvic and lower abdominal pain. Diagnostic evaluation and imaging procedures. When patients present with symptoms suggestive of bladder pathology, comprehensive diagnostic evaluation begins with detailed clinical history and physical examination. Urinalysis provides initial laboratory assessment, though hematuria alone necessitates further investigation to determine its underlying etiology. Advanced imaging studies including ultrasound, computed tomography, and magnetic resonance imaging help visualize the bladder and surrounding structures, providing information about tumor size, location, and involvement of adjacent organs. These imaging modalities prove essential for staging purposes and treatment planning, allowing clinicians to assess whether disease extends beyond the bladder wall. Cystoscopy, the gold standard diagnostic procedure. Cystoscopy represents the definitive diagnostic approach for evaluating suspected bladder malignancy. This minimally invasive endoscopic procedure involves inserting a thin, flexible, or rigid tube equipped with a camera directly into the bladder through the urethra, allowing direct visualization of the entire bladder mucosa. The procedure enables clinicians to identify suspicious lesions, assess their morphology and location, and obtain tissue samples through biopsy. The collected tissue undergoes pathological examination to confirm malignancy, determine the histological type, and assess the grade of cellular differentiation. This information proves crucial for determining prognosis and guiding treatment selection. Cystoscopy can be performed in outpatient settings under local anesthesia, making it a practical diagnostic approach with minimal patient morbidity. Key points: direct visualization of bladder mucosa and suspicious lesions. Real-time tissue sampling through biopsy forceps. Assessment of tumor location, size, and extent. Histological diagnosis and tumor grading. Pathological classification and grading systems. Pathological examination of bladder cancer specimens provides critical information determining treatment approaches and prognosis. The vast majority of bladder cancers originate from transitional cells lining the bladder interior, classified as urothelial carcinoma or transitional cell carcinoma. Pathologists assess the grade of cellular differentiation, with well-differentiated tumors generally carrying better prognosis than poorly differentiated malignancies. The grade reflects how much tumor cells resemble normal bladder epithelium, with higher grades indicating more aggressive biological behavior and greater likelihood of progression. Additional histological variants including squamous cell carcinoma, adenocarcinoma, and small cell carcinoma occur less frequently but often present with more aggressive characteristics and require specialized treatment approaches. TNM staging system and prognostic stratification. Bladder cancer staging utilizes the TNM classification system, which incorporates information regarding tumor invasion depth, regional lymph node involvement, and distant metastatic disease. The staging process begins with the assessment of how far malignant cells have penetrated the bladder wall layers. Superficial tumors confined to the mucosal layer carry significantly different treatment implications compared to tumors invading the muscle layer or extending beyond the bladder wall. The presence and extent of regional lymph node involvement substantially impact prognosis, as does evidence of distant metastases. Clinicians assign numerical stages ranging from 0 through 4, with stage 0 representing the least advanced disease limited to the mucosa, while stage 4 indicates advanced disease with distant organ involvement. This staging framework guides treatment selection and provides patients with prognostic information regarding expected outcomes. Treatment approaches based on disease stage. Treatment strategies for bladder cancer vary substantially based on stage, grade, and individual patient factors. Early-stage superficial tumors often respond well to transurethral resection combined with intravesical therapeutic agents, preserving bladder function while achieving excellent disease control. Muscle-invasive disease traditionally requires more aggressive interventions, with radical cystoprostatectomy in males and radical cystohysterectomy in females representing the standard surgical approach. Neoadjuvant chemotherapy administered prior to surgery has demonstrated improved survival outcomes in selected patients with muscle-invasive disease. Radiation therapy may be employed either as primary therapy in patients unsuitable for surgery or as adjunctive treatment following surgical resection. Advanced metastatic disease often requires systemic chemotherapy, with immunotherapy agents demonstrating increasingly important roles in modern bladder cancer management. Key points: early-stage disease, transurethral resection with intravesical therapy. Muscle-invasive disease, radical cystectomy with or without neoadjuvant chemotherapy. Advanced disease, systemic chemotherapy and immunotherapy agents. Radiation therapy, primary or adjunctive modality in selected cases. Prognosis and long-term outcomes. Prognosis in bladder cancer patients depends critically on multiple factors including tumor stage at diagnosis, histological grade, patient age, and overall health status. Patients with early-stage disease identified through screening programs typically achieve superior outcomes compared to those with advanced disease at presentation. 5-year survival rates improve substantially when tumors remain confined to the mucosa or are detected at early muscle-invasive stages. Conversely, patients presenting with advanced disease involving distant organs face considerably more limited prognosis despite multimodal therapeutic approaches. Regular surveillance following initial treatment remains essential, as bladder cancer demonstrates propensity for recurrence even after successful initial therapy. Close monitoring through cystoscopy and imaging studies enables detection of recurrent or new tumors at potentially more treatable stages. Risk factors and prevention strategies. Understanding modifiable and non-modifiable risk factors for bladder cancer allows patients and healthcare providers to implement appropriate preventive measures. Cigarette smoking represents the single most significant modifiable risk factor, with active smokers demonstrating substantially elevated incidence compared to never smokers. Occupational exposures to certain chemicals in industrial settings, particularly those involving dyes and aromatic amines, increase bladder cancer risk. Chronic irritation from recurrent urinary tract infections, long-term catheterization, or schistosomiasis parasitic infection elevates malignancy risk. Age-related incidence increases substantially after age 65, with males experiencing higher prevalence than females. Previous cancer treatments involving chemotherapy or pelvic radiation increase subsequent bladder cancer risk. Smoking cessation represents the most impactful preventive measure, with risk declining progressively in former smokers compared to active users. Adequate hydration and prompt treatment of urinary tract infections provide additional preventive benefits. Follow-up care and surveillance protocols. Post-treatment surveillance forms an essential component of bladder cancer management, as disease recurrence can occur months or years following initial therapy. Patients typically undergo regular cystoscopic examinations combined with urine cytology to detect recurrent or new malignancies at the earliest opportunity. The frequency and duration of surveillance depend on initial disease stage and treatment modality, with high-grade or muscle-invasive disease requiring more intensive monitoring protocols. Imaging studies including computed tomography or ultrasound assess for evidence of nodal or distant metastatic recurrence. Patient education regarding symptoms warranting immediate medical attention, such as recurrent hematuria or dysuria, empowers individuals to seek timely evaluation. Participation in shared decision-making regarding surveillance intensity helps balance cancer detection benefits against unnecessary procedures and associated healthcare costs. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.